In the intensive care unit, a critically ill adult patient on broad-spectrum antibiotics develops a specific set of symptoms. Their stools turn pale and clay-colored, and their urine urobilinogen concentration drops to absolute zero. To the attending resident, these signals indicate a mechanical blockage. Because zero urobilinogen and clay-colored stools are hallmarks of an impacted gallstone, they begin prepping the patient for an invasive, high-risk surgery to clear the bile duct. But the surgery is canceled. There is no stone. The high-dose antibiotics sterilize the patient's gut, eliminating the anaerobic bacteria required to process pigment. The missing chemical is urobilinogen. It operates as a master communication node deep within our physiology, linking the microscopic ecosystem of our gut to our red blood cells, our liver, and our kidneys. Human cells lack the enzymes required to finish this demolition ourselves. Without help from this outsourced microbial workforce, the processing line for our own cellular wreckage simply grinds to a halt. Once the bacterial crew manufactures this molecule, it follows a strictly regulated 80-20 split. 80% stays in the gut to become stercobilin, which provides the normal brown color of human waste. The remaining 20% crosses the colon wall to enter the portal vein. This schematic maps the urobilinogen molecule. It consists of 4 puryl rings tied together by 3 saturated methylene bridges. This saturation lacks a double bond network to catch light. Unable to reflect light back, it remains colorless. The 20% that enters the portal vein loops back toward the liver. Here, hepatocytes act as a first-pass siphon, snatching up 95% of the returning molecule and resecreting it into the bile to be recycled. Because this hepatic siphon is so efficient, only a microscopic 5% fraction slips past. This tiny amount escapes into the systemic arterial blood, eventually filtered out by the kidneys into the urine. This renal output is minuscule, often less than 1 milligram a day. Because it is so small and so tightly regulated, this tiny urinary exhaust acts as a hypersensitive, dynamic dashboard for the entire human machine. This architecture is not present at birth. Newborns enter the world with a sterile gastrointestinal tract, lacking the bacterial workforce required for pigment conversion. Because the infant has a sterile gut, the raw bilirubin sitting in their intestine is often reabsorbed back into the bloodstream. This unintended recycling loop worsens newborn jaundice until the infant's microbiome matures and begins producing urobilinogen. At the opposite extreme is a pigment storm. This occurs during severe intravascular hemolysis, a state where millions of red blood cells rupture in the bloodstream simultaneously. Historical triggers for this biological dam breaking include severe malaria attacking the blood, as well as modern crises like sickle cell events or mismatched blood transfusions. The liver is flooded with raw pigment, dumping a massive load into the gut. Bacteria hypergenerate urobilinogen at a scale that completely overwhelms the liver's transport aids, causing the molecule to spill over into the systemic blood. When this excess reaches the urine, it acts as a blaring smoke alarm. It proves that a fire is destroying either the red blood cells or the liver's own extraction machinery. A different crisis occurs during a biliary flatline. This is caused by a physical blockade, like an impacted gallstone, that cuts off the liver's connection to the gut. With the biliary path blocked, gut bacteria are starved of raw material. Urobilinogen production drops to zero, and the absence of its downstream pigments turns the patient's stool into gray clay. To locate the exact point of failure, doctors use a functional jaundice differential grid. It plots urine urobilinogen against urine bilirubin to separate a physical obstruction from a hemolytic crisis. Pattern 1 shows a massive urobilinogen spike paired with negative urine bilirubin. This isolates the defect upstream, confirming red blood cells are being destroyed while the liver's plumbing remains open. In pattern 3, an absolute zero urobilinogen reading paired with a positive bilirubin block confirms a post-hepatic obstruction. This signals a surgical emergency, like a stone that must be physically extracted. Far more than a fluid check, the urine dipstick provides a live tracking metric of biliary tract openness and red blood cell lifespan. Reading these metrics in the lab is a forensic challenge. Technicians must trap and quantify a chemical ghost that is naturally invisible. The gold standard for this task is the Ehrlich colorimetric aldehyde reaction. Invented by Paul Ehrlich, the method uses concentrated hydrochloric acid to force the colorless molecule into visibility. The acid causes the invisible bridges of the molecule to snap together with the reagent. This reaction forms a vibrant cherry red complex that automated laboratory machines can scan to measure the precise concentration. However, capturing this measurement is difficult due to a pre-analytical vulnerability known as the light trap. If a sample sits unshielded on a lab bench for just 30 minutes, ambient UV rays and oxygen attack the molecule. They oxidize urobilinogen into a variant that can no longer react with the laboratory reagents. A simple delay in a busy hospital ward erases the evidence. The machine reports a false zero, which could mask an active hemolytic crisis or severe liver damage. Lab technicians also have to watch for a biological imposter. A rare genetic condition called acute intermittent porphyria floods the urine with porphobilinogen, or PBG. PBG reacts with the laboratory acid in the exact same way, turning cherry red and faking a liver failure signal. This creates a diagnostic nightmare that could lead to an incorrect medical intervention. The solution is the Watson-Schwartz test, which uses the principle of oil and water to physically interrogate the sample. As shown here, the test forces the molecules to separate. The true urobilinogen sinks into the heavy organic layer at the bottom, while the imposter remains trapped in the watery layer at the top. Lab supervisors rely on these separation techniques and strict quality control targets to catch ex vivo oxidation and diagnostic imposters before releasing the data to the surgical floor, because every single heavy dose of antibiotics or delay in a laboratory changes how we interpret this delicate architecture. Our biology is deeply interconnected with our microbial guests. We cannot accurately map our own organ failures without reading the invisible chemical footprints they leave behind.